Thank you. This is a daunting challenge to talk about specialists and subspecialists. There are so many different kinds, and they have so many um, different settings that they work in. I just wanted to get some definitions down to begin with. First of all, there are very few general practitioners at all in the United States. It's an old term, and in 1969, family medicine became a specialty, along with internal medicine and OBGYN, peds and psychiatry, and general surgery. Emergency medicine followed after that. So we tend to think of subspecialists as people who've had the extended residency training of specialists, and either a very long residency or fellowship training after their residency time. So in general, you can expect that a subspecialist is someone who wasn't really able to go into practice until he was in his 30s or she was in her 30s. The other thing you should be aware of is the differentiation between board eligible and board certified. Board eligible means you've completed a course of training. Board certified means that you passed an accreditation exam by a specialty society. Most of those societies now require you to recertify on a regular basis, and in some of our specialties, you actually have to do things every year to prove that you've kept up to date, even chart review. I think the first thing we should think about is what's different about subspecialists. Certainly, they have deep knowledge. They've chosen to focus in on a narrower field of care. And while it's narrower, it's quite deep. Secondly, many of the specialists have particular procedures that they do, whether they be hands-on or interview type skills, things that the average generalist would not have been trained to do, would not have enough patience to do it on to get really good at. So that they are procedure-based, and this changes a lot about their relationships to health plans and other payers. The next very important thing is that many of the patients of a subspecialist are episodic, people who come to them with a condition that requires a specific treatment, and once that treatment is done, they return to their primary care. People who have exacerbations of disease that require intensive care and then return to primary care. But there are also many medical subspecialists who follow people with cancer, with chronic inflammatory diseases, and other chronic problems that require intensive care, and they may take care of them for a lifetime. And finally, the subspecialists have some very different business realities. Some of them are the only one in the county, and they're overwhelmed with demand for their services. And while they do have higher incomes, they tend to require higher facility equipment and staffing costs to support their work. When it comes to the issue of utilization, very often costly care is attributed to the subspecialist. And this is a bone of contention because frequently enough, they don't have a choice about whether that care is given. It becomes necessary and they provide it. Finally, they have to pay higher malpractice fees. And the way accountable care organizations are structured nowadays, they usually are not full members of an ACO, but rather work with multiple ACOs. This is extraordinarily complicated for them, since for each of them they have to have separate contracts and payment mechanisms. So they have a very different life than the average generalist.